Currently, bispecific antibodies are given as continuous therapy till disease progression or intolerance to therapy. However, we know that a subset of patients may have sustained remission following a finite or a limited duration therapy. So we are interested in looking into this subset of patients, identify some of the factors predicting relapse-free survival of therapy. So in this work that was presented at the International Myeloma Society meeting, we identified 78 patients among the 720 patients who received bispecific antibody in this multinational effort. For the study, we included patients who received a bispecific antibody or a multispecific antibody directed against BCMA and or GPRC5D. This could be patients who received a standard of care treatment or an investigational product on a clinical trial. So patients received treatment but came off for reasons other than disease progression and had ongoing remission for at least 3 months of therapy. We looked into relapse-free survival, which is of interest clinically. The 24-month relapse-free survival of therapy was 68%. We have 7 patients among the 78 patients who've had remission that lasted for 3 years and more. The most extended remission of therapy was about 5 years. We also looked into factors predictive of relapse-free survival. In this study, the presence of extramedullary disease, higher number of prior lines of therapy, mostly 6 lines and more, and a partial disease remission status at the time of treatment discontinuation was associated with an inferior relapse-free survival. Another interesting finding here is the risk of infection of therapy and the IgG kinetics and IVIG utilization. We know that infection is a serious concern with bispecific antibody therapy, and we wanted to understand, does the infection risk modulate with a finite duration therapy? We found that in patients who've got a finite duration therapy, as in the study, the 24-month cumulative incidence of first high-risk infection was 32%. We also found that the rates of recurrent high-grade infection went down with increasing time of therapy. Indeed, 900 days and beyond post-treatment discontinuation, there were no reports of new first high-grade infection. We also looked into IgG kinetics over time. Most of our patients, as we know, have hypogammaglobulinemia and require IVIG supplementation in a real-world setting. So in this experience, we found that nearly 75% of patients had a low IgG level even 180 days following treatment discontinuation. And 900 days and beyond, 90% of patients had a normal IgG level, showing that there is a slow but steady improvement in the IgG levels with increasing time of therapy. We looked into the trends in IVIG utilization. Nearly 33% of patients in this experience required at least 1 dose of IVIG in a 30-day window period within the first 180 days of treatment discontinuation. Just like with the IgG levels, we found that IVIG utilization also decreased with increasing time of therapy. Thus, we show in this study that a finite duration bispecific antibody therapy may be a good option, at least in a subset of patients. The 24-month relapse-free survival was 68% of therapy. The risk of infection does go down with increasing time of therapy, along with a corresponding improvement in the serum IgG level and IVIG utilization.